Hello, and welcome to this workshop series, Preparing for the New Era of Blood-Based Biomarkers in Alzheimer's Disease, Navigating Guidelines, Policy, and Practice Workflow Integration. I'm Suzanne Schindler, Associate Professor of Neurology at Washington University School of Medicine, and today I'm happy to have Hamid Okhravi, Director of the Shirley and Richard Roberts Comprehensive Memory Center in Norfolk, Virginia, join me for workshop 2 so that we can talk about new developments shaping the use of blood-based biomarkers in Alzheimer's disease. Welcome, Hamid.
Thank you very much, Susanna. I'm so happy to be part of this workshop.
So I'd like to thank PeerView for providing this session and Lily for providing the educational grant for this symposium. Look out for additional polling during the presentation. Please respond to polls on your screen and enter questions in the chat window. Visit us at peerview.com/plasma. The slides and practice aids can be accessed in the activity menu now and downloaded after the session. During today's workshop, we will learn that new evidence and updated guidelines are supporting the expanded role of blood biomarkers in diagnosing early symptomatic Alzheimer's disease. Clinical decisions regarding blood-based biomarker testing can be guided by emerging recommendations to improve diagnosis and patient outcomes in patients with cognitive decline. These are the speakers today, myself and Dr. Okhravi. What is the rationale for blood-based biomarker testing in clinical practice? Well, there are large desirable effects to performing blood-based biomarker testing. Compared to amyloid PET scans or CSF tests, it has reduced physical discomfort and anxiety for patients. It can streamline the diagnostic process, leading to earlier identification of Alzheimer's disease pathology. This may facilitate earlier clinical diagnosis and treatment initiation. It also can reduce delays, repeat referrals, and overall burden on patients, care partners, and the healthcare system. We think that blood-based biomarker testing compared to other types of testing has relatively low undesirable effects, especially when used appropriately. However, if these tests are not used appropriately by trained personnel, false negatives could delay treatment and false positives could result in unnecessary treatment. High accessibility of these tests could lead to overtesting in individuals with a low pretest probability, and some settings may not have ready access to appropriate follow-up. So it's important to use these tests appropriately. The Alzheimer's Association has formulated clinical practice guidelines for using blood-based biomarker tests in the diagnostic workup of suspected Alzheimer's disease in specialized care settings. There are 2 ways to use these tests. Triaging tests must have at least 90% sensitivity and at least 75% specificity. Because of the high sensitivity, a negative result rules out Alzheimer's disease pathology with high probability. Because the specificity is lower, a positive result should be confirmed with another method, typically CSF or amyloid PET. Now, if these tests are very high performing with greater than 90% sensitivity and specificity, they can be used as a confirmatory test. This means that they do not require an amyloid PET scan or CSF biomarker test to confirm the results. This is because that 90% sensitivity and specificity is about the characteristics of what we currently see with FDA-approved CSF biomarker tests. So the blood tests are, in effect, just as accurate as the CSF tests. Now, it's important to note that at present, we only recommend performing biomarker testing in patients with objective evidence of cognitive impairment as part of a full diagnostic workup in specialized care settings with consideration of pretest probability of Alzheimer's disease pathology. Those are the recommendations of the clinical practice guidelines. There are some additional recommendations and guideline considerations. In particular, blood-based biomarker testing may not be appropriate or should be interpreted with extra caution in some scenarios. For example, patients who are not candidates for or have already made a decision against anti-amyloid therapy and who do not wish to know their amyloid status. So we only do these tests in patients where we think the result will help us with a more accurate diagnosis and management plan with the full support of patients. We also would not recommend testing if the patient has obvious modifiable or temporary conditions. We would want to address those conditions first before doing testing. We wouldn't recommend testing in patients with a limited life expectancy. And patients that have conditions that could affect the brain structure or might affect the levels of blood biomarkers, we would probably not perform one of these tests, but rather use a different type of test, for example, an amyloid PET scan if we really needed to know their amyloid status. There are some medical conditions that could affect levels of blood biomarkers. So, for example, I would not perform a blood test in someone who had any kind of acute brain injury or stroke. In patients with severe chronic kidney disease, we would typically not perform blood tests and would instead perform, for example, an amyloid PET scan. There are a few medications that have been shown to affect the levels of blood based biomarkers, so namely neprilysin inhibitors. Um, and so, if you have a patient on a medication like Entresto, we would recommend using a different type of biomarker modality. Before we move on, please take a moment to answer a follow up question on the clinical use of blood biomarkers for diagnosing early symptomatic Alzheimer's disease. It's very important to understand that blood based biomarker results must be interpreted in the context of the patient's clinical symptoms and pretest probabilities. So let's imagine that we have a biomarker test that has a 90% sensitivity and specificity for amyloid pathology. And we use that same test in two different patients. The first patient is a 75-year-old with a typical 80 dementia syndrome. Based on the literature, we see that that patient has a very high likelihood of having amyloid pathology, about 85%. If the result is positive in that patient, about 98% of the time, the patient actually has amyloid pathology. So we can believe a positive result in that patient. However, if the test is negative, there's a reasonable chance that it's a false negative. Now, let's do the same test in a 60-year-old patient with subjective cognitive decline. Based on the literature, we see that that patient has a much lower pretest probability of amyloid pathology. Now, if the test is negative in that patient, 97% of the time, they do not have amyloid pathology. So we can believe the negative result. But if the test is positive, there's a fair chance that it's a false positive result. So, what does this mean? It means that if the test result aligns with our clinical suspicion, that we can believe it. However, if our test result doesn't make sense, given what we know about the patient, then we need to think some more about it, maybe do some additional testing. One way to think about this is that we treat the patient, not the test, and we keep looking when things don't make sense. Now, if you're interested in calculating or estimating these pretest probabilities yourself, you can use this Shiny app where you can plug in patient related factors to estimate this likelihood because it really does affect the way that you think about the certainty of the test result. Now, guidelines have been prepared for thinking about how to use triaging and confirmatory blood based biomarker tests, both in primary and secondary care. And this paper goes through the details of these recommendations. Some key differences are that in primary care, we actually recommend that triaging tests perform better, that they have a higher specificity um, of at least 85%. And that's really because primary care doctors have less access to confirmatory tests. And so if someone has a false positive result, it takes longer to get that second test to find out that no, the patient does not have uh, amyloid pathology. Across the board, we think that the tests should have high sensitivity. This is because we don't want to miss people who do have amyloid pathology. Now, Hamid, I'll pass it to you to tell us about two FDA cleared blood tests that we now have to help clinicians detect amyloid pathology or to help rule out Alzheimer's disease pathology, both in secondary care and now in primary care settings.
Thank you, Suzanne. Yeah, so there has been now two of these plasma biomarkers that are FDA cleared. The first one is Lumipulse, which is from Fujiro Bio, and that measures the p-tau 217 over amyloid beta 42 ratio. And this is cleared to detect Alzheimer's pathology in patients 50 years and older, presenting to specialized care setting. Who have signs and symptoms of cognitive decline. Again, this is not designed for asymptomatic patients. So now I want to just draw your attention to the right side of the this slide. As you can see that scatter plot. So there are two cutoff points for this test. There's a high cutoff and then low cutoff. As you can see here in red, those measurements that are above the high cutoff, that means that the test is positive and the amyloid pathology is likely. So when the test is positive, there is no further need for any additional testing. So that confirms the diagnosis of Alzheimer's or at least presence of amyloid pathology in the brain. Now, if you take a look at the measurement under the low cutoff, which is in green, that means the test is negative and the amyloid pathology is unlikely, meaning that probably the cause for patients' cognitive decline is not related to Alzheimer's disease, and you need to check for other causes. But with this test, there is a 20% chance that the result can come back intermediate. And what it means that the amyloid pathology is uncertain. And when that happens, we need to consider further testing, like performing spinal tap for CSF analysis or amyloid PET imaging, or maybe just wait for probably another year and repeat the blood test. Now, few things to just point out that this test is not intended as a screening or standalone diagnostic test. So it must be interpreted in conjunction with other patient clinical information, as Dr. Schindler mentioned. So we need to do a comprehensive assessment, of course, in a specialty care setting, interview of patient, family members, and maybe running some labs and doing some neurological examination and probably doing some memory tests as well. And this test could be interpreted within that clinical context. The other thing which is very important is to remind us the cutoffs may vary by laboratory, so we need to interpret results using the cutoffs established by the performing laboratory, the laboratory that we have actually sent the lab to. And last thing is that this test is available through any CLIO laboratory. For example, Quest and LabCorp, they do carry this test right now. The next test that got the FDA approval in October is the Roche's Alexis that measures p-tau 181. And this test was FDA cleared to help rule out presence of Alzheimer's pathology in patients 55 and over who present to primary care setting, who have also signs and symptoms of cognitive decline. Again, this is not recommended for asymptomatic patients. Now, here we have one cutoff point, and the test is considered as positive when the results are above that cutoff point. And what that means is that the patient may have amyloid pathology. And as you can see, the positive predictive value is 22.4%, so that's low. And for that reason, when this test is positive in primary care setting, probably the best action would be to refer to specialty care for further assessment by CSF analysis or amyloid PET imaging to confirm Alzheimer's pathology. And if the results is under that cutoff point, that is the negative result, and that is consistent with patients unlikely to have amyloid pathology. So as you can see, the negative predictive value is quite high. That's almost 98%. So you can almost by certainly say the problem with memory, the cognitive decline most probably is not related to Alzheimer's or Alzheimer's pathology, and you really need to look for other pathologies, other causes. Now, with this test as well, uh, of course, tests will not give an Alzheimer's diagnosis, and it's not intended to be used standalone. Um, Test results must be interpreted in conjunction with clinical information, as I explained before. And again, the cutoffs may vary by laboratory, and we need to interpret results using the cutoff established by the lab that we have sent samples to. But now, this is really just hot off the press, I would say. This is from the clinical trials in Alzheimer's disease meeting that was last week, and this study was presented. This is about, again, the Alexis p-tau 181 measurement in the real-world primary care settings. And these primary care settings are from different countries, including U.S. And as you can see on the left-hand side, the ROC AUC, there's a good discrimination of positive and negative status for amyloid PET results by visual rating. And at the primary care specific cutoff point, which is 0.722 picogram per milliliter, this test showed really high performance for ruling out amyloid pathology in primary care setting. So when you take a look at the negative predictive value down there, you can see that's 97.9%, almost 98%. So it's quite powerful. So if the test is negative, you can say reliably that the patient probably does not have Alzheimer's, or Alzheimer's is not the cause for cognitive decline. But Suzanne, what are your thoughts about this study? Anything you'd like to add?
So one thing about the study population is they had quite a low rate of amyloid pathology in their group. And so I think that this test would be helpful if you had a low suspicion of amyloid pathology. So if you had younger patients who did not have significant objective evidence of cognitive impairment, so very mild symptoms, and maybe you thought there were other potential causes of their cognitive impairment. So you can't rule out Alzheimer's based on clinical features, but you don't think it's very likely. That would be the kind of patient. So those are the kinds of patients where I would think about using this test. However, if I had higher suspicion, I would use a different type of test. So that's the sort of thing that providers need to think about before they order the test. What am I going to do next? If my suspicion is high, is this really the most appropriate test? So there's lots of caveats to using this particular type of test.
So it seems that they need to know their demographics about the prevalence of the Alzheimer's pathology as well. And that's very helpful. Thank you. Now, in terms of the coverage for these blood-based biomarkers, it's kind of interesting that almost always when I start talking about these tests, the patients and caregivers ask, who's going to cover the cost, which is quite important because these tests could be still quite expensive. I think the cost could be something from several $100 to maybe $1,500. And I think right now the coverage is a little bit sketchy, at least based on my experience. I've been ordering these tests for the past 2 years. It's actually getting better a little bit, but still, there's some issues. But I think these coverage for blood-based biomarkers right now, because of the FDA clearance of those two blood-based biomarkers, are getting a little bit better. but still, Medicare has no national coverage determination, NCD, for covering the cost, but there are some movements going on. For example, Alzheimer's Screening and Prevention Act, which was introduced in November. Uh, and if that passes through, that would authorize CMS, of course, Medicare, to cover FDA cleared blood based biomarkers for early screening in Medicare beneficiaries. Right now, the commercial and Medicare Advantage plans uh, they go case by case. And what I really recommend for those of you who are going to order these tests, make sure that you mention very clearly the medical necessity for these tests. And also document how it's going really to change your management. So this will increase the success rate of getting covered. Right now, most private insurance they require PET scan and CSF to authorize treatments for these anti-amyloid therapies. So if that's the case, probably patients need to have those two tests done rather than blood tests. But Suzanne, what has been your experience with this? Have you noticed that insurance companies are starting to cover tests in the wake of these new approvals?
So, just as you were saying, I think that it's kind of patchy and inconsistent. In general, I have not had patients complaining that they've had to pay for these tests when I've ordered them. So that's a good sign. I always tell patients that they may end up with a bill for it or may not. It's really unclear at this point. Um, I do think these are increasingly being covered, and I'm seeing more and more primary care doctors ordering them, and patients have not complained to me about the cost. So I think that's a good sign. But we really do need consistent coverage to feel confident ordering these tests in more patients, and hopefully that will happen in the next year or so.
And based on my experience, some of these companies they do have a very good and strong patient assistance program. It's actually very easy to apply, and some of my patients have done so, and so that has really helped significantly as well. So that's another thing to consider when we order these tests.
Yeah, that's a good point. Some of these companies do have those plans, and that can really reduce the cost of the test down to even $50, which is really quite affordable for most patients.
So now, Suzanne, I'm going to just hand it back to you.
So, where are we now in terms of the use of blood based biomarkers? Well, in primary care, we can use them as a triaging test to rule out amyloid pathology in symptomatic patients. We can also use them to determine whether patients may be eligible for amyloid targeted treatments. The appropriate use recommendations for at least one of the amyloid targeted treatments recommend that high performing FDA approved blood tests with greater than 90% sensitivity and specificity can be used to confirm amyloid pathology and start treatment. And we have done this at my own institution. Notably, Medicare may accept blood based biomarkers as adequate evidence of amyloid pathology, but private insurance at this point usually requires CSF or amyloid PET tests. So be very aware of these insurance issues. A common question is, can we monitor treatment response with amyloid targeted treatments with blood tests? And the answer right now is no. We still need amyloid PET scans to establish that amyloid has been cleared from the brain. The blood tests just don't tell us with enough certainty. Another question is whether patients with subjective cognitive decline can undergo these tests. At this time, we think that these tests are only appropriate for use in individuals with objective evidence of cognitive impairment, although this is an active area of discussion. So, what's next for blood based biomarkers? So, something that I'm interested in is staging Alzheimer's disease biologically. This is helpful because you can understand not just whether someone has Alzheimer's disease pathology, but how far advanced it is. So there was work recently presented by Dr. Gemma Salvato at the Clinical Trials in Alzheimer's Disease Conference that showed that you can use percent p-tau217 and another analyte, emTBR tau 243, both in blood, to stage individuals in terms of the biological severity of Alzheimer's disease. And the stages based on these two plasma biomarkers were very consistent with neuropathological stage as well as stage by PET scans. So I think this is potentially a very helpful development, especially as we're thinking about individuals where we're less certain about whether their symptoms are due to Alzheimer's disease pathology or other causes. Hamid, now I'll pass it back to you to translate emerging clinical guidance.
Thank you, Suzanne. This is just a case that really happens, I think, in our memory clinic and also in primary care settings as well. I get quite a few referrals like Margaret here. So Margaret is a 68-year-old woman, presents to her primary care physician, and the concern is that she's getting concerned about her forgetfulness, such as forgetting about scheduled appointments and plan get-togethers with friends and family. And memory lapses have become more frequent over the past year, so it's been progressive, so that's concerning to the patient. But she's able to manage it by leaving reminder notes for herself. Before we move on, please take a moment to answer a follow-up question on blood-based biomarker testing. So Margaret's primary care physician does the clinical assessment and interviews, of course, Margaret and her husband. Her husband also corroborates to the concerns that Margaret brought up. PCP checks medications. There's really no red flag there. Does the neurological examination and basic labs like TSH, B12, CBC, CMP. And those are unremarkable. And patient has a history of depression. Margaret has history of depression, but that's reasonably treated. PCP does MoCA, Montreal Cognitive Assessment, and the score is 24 out of 30, with 1 out of 5 on verbal recall. So essentially, the short-term memory part was affected. So this is amnestic presentation, and there's no family history of Alzheimer's, and patient is independent in performing basic and instrumental activities of daily living. Her PCP comes up with the diagnosis of mild cognitive impairment, MCI, and believes that the underlying cause of her symptoms could be due to Alzheimer's disease. And PCP has discussion about further workup and offers two different things: to either do the blood test, the blood biomarker for Margaret, or make a referral to see a specialist. But of course, that takes a few months probably to have it done. And after discussion, Margaret decides to go with the blood-based biomarker, and that will be that is ordered by the PCP. So, Suzanne, where do you think Margaret falls on the likelihood spectrum for Alzheimer's pathology, and how does that influence whether and how you'd use a blood-based biomarker test for Margaret?
So Margaret's a little bit on the younger side, so only 68 years old. So that somewhat decreases the pretest probability of having amyloid pathology. However, both she and her husband have noticed some amnestic symptoms that have been slowly progressive. Her MoCA score is impaired, so she clearly has objective evidence of cognitive impairment. She has a history of depression, but that's pretty nonspecific. And I'm not really hearing other reasons that explain her cognitive impairment. So I am pretty concerned that this could be Alzheimer's disease and at its very earliest stages. And I would certainly want to do biomarker testing. She may be an excellent candidate for amyloid targeted treatments.
So, if I asked you to give a number about the pretest probability, what would be your guess here?
Well, again, she's on the younger side, and this is MCI, not dementia. So I think based on the literature, I would probably guess 60 to 70%, something like that.
Yeah.
What about you?
Yeah, that's
What would
exactly
you
what I
guess?
was actually thinking. Probably about maybe 50, 60%
Mhm.
pretest probability, which is quite good and high enough to move forward with blood-based biomarkers. So before we move on, please take a moment to answer another follow-up question on blood-based biomarker testing. Um, to conclude our discussion on the remarkable progress we made with blood-based biomarkers, let's just focus on a few take-home messages. First of all, blood-based biomarkers test results, first of all, needs to be interpreted within the context of patient's clinical picture, as we discussed before. Um, we don't really order them in asymptomatic patients. Uh, when implemented thoughtfully and appropriately, these tests are quite scalable and, of course, patient friendly. Everyone has done blood tests, so that's easily acceptable by patients. And then that can lead to early detection. And specifically right now, because we have these disease modifying agents that are time sensitive, that hopefully can lead to earlier initiation of therapy for patients and better results. Well, of course, FDA has cleared a couple of these blood-based biomarkers and others are coming, but still insurance coverage is an issue, but that is evolving. And last but not least, it's very important to always remember reference labs may use different cutoffs. Always, we need to interpret results using the cutoffs provided by the performing labs, even for those FDA cleared assays. Um, so I think this has been really a great discussion about some of the latest scientific and regulatory developments that are shaping the use of blood-based biomarkers in clinical practice. Suzanne, I will pass it back to you.
Dr. Okhravi, thank you so much for this discussion about blood based biomarker testing in Alzheimer's disease. And thank you all for joining us today. The next webcast in this series will air on January 29th, 2026 from 7 to 7:30 p.m. Eastern Time, where I will be joined by Dr. Lauren Vandevrede to discuss how to put blood-based biomarkers to work in real-world Alzheimer's disease care. Thank you for joining us. After this session concludes, visit peerview.com to claim credit and access the activity materials. Stay tuned for the online activity based on this event.